welcome once again on behalf of our organizational committee. We are present today at the conference, working with the traumas of the war, the SETA achievements and the experience for 23, 24, 22nd, 24th, the years of the full-scale war. Many thanks for your interest to today's event. That means that SETA is something dear to you, something that you have joined one way or the other, or something that is really alive, that is in progress, in development, in improvement. And we have prepared quite an intense program for you. We, by our team of coaches, we have talked and we decided to focus on certain themes that I believe would be interesting and useful for you. So SETA is the life body, and the experience which we're working on together has to be spread around. And today's main objective, apart from seeing each other, is exactly about spreading the accumulated experience, so you would also know about it and you can also use it in your practices. You will have the possibility to ask questions that will be up during the conference, but please get yourself ready that the majority of the conference will be about seeing and listening, but every presentation will have the Q&A session. First of all, you can do this via chat, and I'm as the moderator, I will try to monitor the chat and ask the questions to the speaker, but in case I don't see somebody, you can ask this question again or put in chat once again. So today we are gathered to discuss the most actual topic. It's about working with the traumas of the war. We are trying not only to summarize our achievements, but also outline certain prospects for the future work, because I'm saying this for the third time, SETA is developing, and it's important to understand in which way we should direct our effort to make SETA, let's put it this way, even more effective, and the one that would meet the challenges which are just starting and will be manifested even more in the future years. I'm very much sure that our today's event will be the platform of getting new knowledge and inspiration for the future work. And I would like to pass the floor to the person who you all know, Sergei Bogdanov, the president of the National University Kyiv-Mohyla Academy. Sergei, would you do the presentation? Oh, so far, let's have the welcome words. Yeah. Thank you, Pavlo. I would like to welcome all the participants of the conference. I wanted to say thank you and to say best regards from Sergei Kvit, the president of the Kyiv-Mohyla Academy. He is now returning from the trip and he's simply not being able to reach internet, but it's very important for him and the activity of our center. So he has asked me to pass his sincere regards to the participants of the conference, and also to say on behalf of him and on behalf of the university to say a few words for all the participants. Kyiv-Mohyla Academy, starting from 2014, when just the war broke out with Russia, it implements programs of mental health for the Ukrainians. So we are cooperating with the national partners, with international partners, to make sure we can help people stay strong, preserve their mental health. And as the leading science and research university in Ukraine, we are trying to make it in such a way that people, the clients who are getting the services from us, so they would know that these values of the Kyiv-Mohyla Academy, the quality, the transparency, the trust, that these values are manifested in our projects, in our programs, something that we do for the people. Today we are presenting the results of one of the very important, and I believe for Ukraine, the program of supporting mental health. That's the SETA program. This program we started to implement back in 2015. This was the USAID supported project together with the experts of Johns Hopkins University, SETA Global, and I'm very happy today that with us we have Stephanie Skavinsky, who is one of the authors and one of the people who have invested a lot to make sure that this SETA program would take place in Ukraine together with her colleagues. And I would like to say on behalf of the university that we are very much thankful to our partners for the possibility to create high-quality, accessible service for Ukrainians and support it throughout the last 10 years for people who really require this. And after 10 years of implementation of SETA in Ukraine, we definitely know that such program is really, truly one of the best in Ukraine. We know this from the scientific research which we are conducting. We know and we're hearing numerous responses, feedback from the clients, from the students, from the instructors of the Kyiv Mohyla Academy. We have also received and we have shared these responses from partners, from the people who have learned to implement this program in Ukraine. And today, I believe that we should have all very fruitful discussion. Mr. Pavlo has mentioned the topics on which we want to, in the first place, to share the achievements, but also at the same time to still consider how we can proceed further and how we can further strengthen the system of the mental health system in Ukraine. Therefore, I would like to wish everybody fruitful work. Many thanks to the team, many thanks to SETA for them working all of this 10 years, continues to work, and continues to work, and all the organizers of the conference who are, irrespective of all the difficulties and that we have, we were able to get together and to present these results. Thank you, Pavlo, and passing the floor back. So, our conference is started, and it is my pleasure to pass the microphone. Sergey has already talked about Stephanie. We can actually call Stephanie one of the three mothers for SETA. I don't know the grandmother of the ones whose SETA coaches have trained. So Stephanie Skavinsky is the master coach of SETA Global, the member of the team who has created SETA with the Bloomberg School of Mental Health at the University of Johns Hopkins, and just a good person who really has invested so much to make sure that it has the shape that it has in Ukraine. Stephanie, it's now the time for your presentation.
Oh, first I'm going to take myself off of mute. That always helps. Can everyone see my screen?
Yes.
Great. Great. Well, thank you so much. I apologize because my slides are not in Ukrainian, but I will do my best to speak slowly and hopefully, of course, there's translation. So we will be sure to get these translated, and if people want copies of them, we're happy to send them out. Well, thank you so much first to Naugma and to Dr. Bogdanov for inviting me to be here today. Very excited to see some wonderfully familiar faces. I also want to thank USAID, of course, our funder who has funded a lot of the work that we've done with SETA, not just in Ukraine, but globally. And of course, a final thank you to the entire team at Words Help and Naugma who have worked tirelessly day in and day out to serve quality care to the people of Ukraine. So a huge thank you. My name is Stephanie. I'm from Johns Hopkins, I think, as Pavlo said, and SETA Global, and have worked with this team for over 10 years. So I can't believe it's been a decade. I'm just gonna... So I just wanted to talk a little bit more about the background of SETA. I don't know how many of you on the call and conference have heard about SETA before, but you know, as a team at Hopkins and at SETA Global, we've really looked at the situation of mental health care today. And many communities, not just within Ukraine, either don't have a system of care or have gaps in the system for mental health care for a variety of reasons. In Ukraine, of course, with the recent invasion, there have been movement of people, structures that have been destroyed or missing that are necessary or usually there in a healthcare system. Mobility of people have been limited due to safety precautions. And of course, in humanitarian crisis, people have varied needs at any given time. And as a team, we started to think about what if there was a better way to build a mental health system of care? What if communities could easily access a system where their needs could be determined at the right level of evidence-based care at the right time? And what if that system was already globally trialed in Ukraine specifically, and proven to treat patients in 78% less time than traditional care? And that's where the SETA system of care comes into play. We see traditionally with mental health care that there's a siloed approach. There's interventions that are specifically for depression, anxiety, different interventions for substance use, different interventions for safety. And, this system, that if it's built on traditional siloed approaches, is time consuming, expensive, and unscalable. You would have to train providers in 5 to 10 different interventions just to treat the needs of a population. And I think in Ukraine, that's what we're seeing is there's sort of self-help plus, PM plus, EMDR, TFCBT, and you have a variety of different interventions, but not one cohesive system. And this slide really is just to show the cost effectiveness, right? If you had one system of care to train providers in, and the providers can be paraprofessionals all the way up to professionals, versus training professionals and paraprofessionals in each of these different interventions, it's very costly, time consuming, and not very effective, let alone feasible. It's really hard as a mental health professional myself. I would find it hard to learn and stay adherent to all of these different treatments. So what is SETA? Well, SETA is an evidence-based transdiagnostic approach. It addresses trauma, substance use, violence, depression, anxiety, in 8 to 10 sessions, and clients can be seen just by one provider. So it's a one-stop shop for everyone, and it can utilize both paraprofessionals as well as professionals. So you really have a more efficient system of care, using people where they're best able to serve and allowed to serve populations. SETA also addresses the lifespan, so we can, all the way from childhood to aging adulthood, and every part of care within the mental health, from wellness and prevention all the way up to treatment and recovery for those with more acute or severe symptom presentations. This slide is a little bit wrong in that we just completed 2 more trials. So we have over 8 randomized control trials at this time. But this slide really is just helping to show the effectiveness of SETA compared to focal treatment. So, if you treat the whole person, if you treat all of their different symptoms and problems, you're going to have more effective and efficient treatment than the sequential approach. The other thing that we think about and use in the SETA system of care is really precision-based treatment. So we're using a routine symptom measurement to inform care. All providers, whether you're doing a 1 session of SETA psychosocial all the way up to full SETA treatment, we're really using a regular monitoring form to track and measure clients' symptoms to make sure they're getting better. This really helps and allows for better treatment planning and changes based on emergent needs. So again, when you think about sort of changing situations, a crisis that goes into kind of longer term care and needs, the providers are trained to be able to respond to that and use their different tools within the SETA approach to respond to clients' needs, which obviously results in improved outcomes for the clients, which is what we care about, making sure that there's quality care. This also really helps with working with paraprofessionals. You have a system of care to make sure that paraprofessionals are adhering, that the clients that they're seeing are getting better in a tool for supervision to help make sure, again, that you're offering always that quality care. The other thing that we really think about when we think about a system of care is ensuring that there's a flow, a workflow. And that flow has to start with an assessment and then triage to ensure that you're providing the right intervention for the right person. And so here you can see that, within the SETA system of care, we have a streamlined one-stop service where you can assess, triage, and then use paraprofessionals or professionals to address the multiple different needs of individuals and a population. The other thing that we find that's really critical in quality care is supervision support. Within the SETA approach, we really have an integrated coaching and supervision throughout. We really believe that that results in improved fidelity and effectiveness because we care about our providers. And I think that, Pavlo, Vera, Oksana, and Nina can speak to this, but during, the pivot and the crisis, providers were living this and have their own needs and their own families, and that making sure that their supervision really reduces provider stress and burnout, improves provider retention, and ultimately that saves costs in the long run. And this, again, really just assures that we're taking care of our providers. When we think of SETA, I think another issue that often comes up is that it's seen as expensive. And, we appreciate and know that funding is often limited. It's great to have easy, simple interventions. And of course, that can be faster and cheaper, but it loses sight of those with more moderate or significant problems. You can do something that, is simple and easy, a one-off intervention that's quicker to roll out, but that's not going to treat trauma or comorbid trauma and substance use or suicide. And so, we do believe that SETA, you're paying for effectiveness versus non-tested interventions, that you're paying for an intervention that can really treat the moderate to severe need of the population, and, that it includes the whole system of care. I think the other thing that we would really stresses, I think there's misconception because a lot of the work that we've done with Johns Hopkins is around trials, and there's a very different expense to a trial. Trials require really rigorous data tracking and monitoring. Even implementation within a trial, it's hard to pick out the costs. And in Ukraine, we're past that point. We've run trials. You have 4 amazing SETA trainers already in country, as well as 3 CPSS trainers. And so implementation costs are just really different than those of a trial. So I wanted to quickly, that's a little bit of background of just the SETA system of care and approach, but I wanted to talk a little bit about how this worked in Ukraine. The system of care within SETA really fits into an MHPSS crisis response system. So it's easily pivoted. Again, we're looking at the same system. We want to be responsive to assess what the needs are of the population, triage appropriately to the right level of care based on the client's needs, and then make sure that you have a constant loop of feedback to ensure clients are getting better, and we're understanding what the varied needs might be as things change over time. In Ukraine, when this invasion occurred, the team really activated the SETA providers that existed. So at the time, we were, I think Naukma and Words Help was already running a program. There were over 200 providers already trained in SETA, and they were activated to really respond to the crisis. What you'll see here on the right of the screen is the crisis response, so the humanitarian crisis response SETA, which includes some additional assessments, because if you have someone that's in safety, or has some basic needs, you want to respond to them differently than someone who's in a longer term situation and more stable and could get maybe that mental health longer term treatment. We worked with NAUCMA and Words helped to really build a technology system to track and monitor and to reach more people in need, especially as people were moving and access was more limited, and provide services and referrals based on each individual's need. And so this system really did include a multi-pronged approach to increase access to care. This was a social media response, QR codes that people could access, as well as just flyers that were handed out in different locations. And all of those led to one simple referral source. So people could access this client request form through their phones, through tablets, through providers who were meeting them at different locations, through filling out this form with very basic information. The information is then sent to a incoming triage process. We want to use technology. Ukraine is a very technology savvy country. And so, using and utilizing technology to take some of the burden off of the workforce is really, really helpful. So the triage requests would come in. The team at Words Help and NAUCMA would work to really look through requests, respond to urgent safety and urgent basic needs, and then refer and assign providers within the SETA team to each of these different individuals requesting services. The technology also helps as a case management board. So if you're running, services, you can really use this to monitor caseloads, workflows, understand the different needs of the population that's coming in. It also helps really understand your workforce. Sorry, I was like forgetting my words. So really understanding your workforce needs. Again, in humanitarian crisis, your workforce is also moving. They have varied needs. And so you can track their own safety issues, their caseload slots, and make services much more efficient. And providers themselves could manage their own workloads. So going in and understanding when a client was finished, making sure that they're tracking and monitoring their client progress. This is a great supervision tool as well. And then as a project management team, we always want to make sure our system there's really a constant feedback loop so that we're understanding what's the demand, what's the workforce, what's the flow, what are the needs that we're seeing to make sure that we're being responsive. And this also really results in easy data pulls. At any point, you can pull where are requests coming in from, what's the level of need of those requests to make sure that you're able to respond. And where are the referrals coming in from, as where are the SETA providers referring out to? This really makes for, again, a responsive entire health system, because this information is really critical to feed back into the larger healthcare and governmental systems to make sure that they're responding to the varied needs that go beyond mental health care. I'll just wrap up with saying that within this system, the team worked, again, very tirelessly to make sure that they were providing quality care, that there was a constant feedback loop. We offered, kind of opportunities for providers as well as clients to feedback about their thoughts about the system, about SETA, and about the response. Overall, the outcomes really were fantastic, that you had an ease of access to really be able to reach those that are underserved, that really needed that higher level trauma, substance use, or safety treatment, that communities have access to evidence-based care, that they're not coming back into the system because there's greater need, or some needs were met, but other needs weren't met. I know that the team still receives 40 to 60 or more requests a week. There's a wait list for care. But because of this efficient system, they've been able to reach over the past few years hundreds and hundreds of clients and serve many. So I will just end again with that, I think in Ukraine, you're in such a critical point where you have this capacity that could really easily be utilized to serve those, especially with more moderate to severe needs. So thank you all for your time. And of course, please reach out if you have any other questions or concerns.
Thank you so much, Stephanie. Хотів би від себе підкреслити декілька речей, так ти що побачив зараз в презентації Стефані. По-перше, що СЕТА створювалась для того, щоб
I would like to add that SETA was created in order to provide services to those who need them, services which they need today at this moment. And that was very, very important, so that you could see that SETA is not only therapeutic services, but also has a managerial framework which is unique, so that people knew whom to address, how therapy results can be traced, and we have a team doing it. Do you have questions or maybe some comments? I think there is a question in the chart.
Спускаюсь вниз. Так,
yes, I'm going down. How did you check the effectiveness of the referrals? Because we heard clients complaining about the triage.
Yes, Stephanie, there is a question from a participant. How we
but I have translated the question.
Of triage, or have we investigate the effectiveness of a referral system? Because the
so how did the referral system work?
Some questions,
because we received
critical points that focused on this triage system and referral. Maybe that is the question: how the referral system was developed, how we measure this needs and refer person to appropriate level of care.
Sure, yeah. I mean, and I'm sure that, Oksana, Nina, Vera, and Pablo, you can speak to this. I think that, at a time during the crisis when the SETA system of care pivoted to this response system, there was a very high demand and a high demand over time. And part of the limitations of a triage system and referral process can be funding, right? And so, of course, when there's longer wait lists and challenges like that, that can be very difficult. And of course, we want to create a system that really meets the needs and demands. And at the same time, we were working with one system. There were very limited other services. And so, the small program at the time was trying to meet the needs of a much larger population. And that's why we're trying to think about countrywide when we think of next steps for SETA and SETA scaling the system, that of course we would want to think about sort of what are the needs countrywide and how can we respond to those and have a system that's really much more responsive at that time. I think that was partially some of the challenges that we faced in those moments, because it was a very small program that was trying to meet the needs of far more than we had the resources to do so. I will say that in other places like the US, we are looking at the system, the triage process and how it fits within existing services. And, I think that that's part of the reason why we have this constant feedback loop is we want the feedback from clients to understand how do we improve the system. Nothing is ever exactly perfect or going to meet the needs of everyone right at that moment of starting. So we really need that feedback loop to make sure we're creating a more efficient system at all times. And I apologize, I have to jump off, but I will follow up with Sergey and the team. If there's any other questions, please also always feel free to reach out to us directly. And we will make sure that we translate the slides and get those to folks. So thank you everyone so much for your time.
Thank you, Stephanie, for your presentation, for your attention to СЕТА in Ukraine. Thank you.
Thank you all for all your
Have a good day. Це Лена Костюк, яка задавала питання.
Lena Kostjuk, who asked the question, I can add that complaints about the triage was connected with the fact that they had to spend several months in the waiting list before the triage takes place, and Stephanie, the clients are referred to specialists. Unfortunately, we have financial restrictions, and our consultants also have certain limits. So in order to give at least some assistance to all those who needed it, we had to make waiting lists. Now let us go on. Now I would like to give the floor to Serhiy Bogdanov, and he will present the results of our activities in 2022-2024 and major achievements of the projects. Now, Serhiy, the floor is yours. Are the slides ready? Can we see them?
Пише, що ні, я не про це.
Now, Olena said in the chat that it was not what she meant. So could you please explain what you wanted to ask about, and then we will try to achieve here. Yes, it's the first slide.
Я його не бачу, колеги, ви його бачите?
I don't see it. Do you see it? The interpreter doesn't see it either. On top, you have both the Ukrainian and English screen. Yes, we can see it.
Добре. Ну, окей, тобто учасники, я так розумію, що...
So I understand that participants see it. Participants can see it. So СЕТА Україна Comprehensive Mental Health Support Program, it is the first slide.
Наступний слайд.
So can we move on?
Програма СЕТА Україна впроваджується з 2015 року.
Yes. Just a moment, please. It's they're having a technical issue.
Побачення, бо якраз його не бачу. Так, все, тепер бачу. Дякую.
Now I can see my slides. So again, I would like to start with the statement that СЕТА is a part of USAID programs, and thanks to the assistance of that agency, we can discuss the results of this project, and we had it, and it was very successful. Starting in 2015, we have been introducing this project in conjunction with the Kyiv-Mohyla Academy. They and Johns Hopkins University, they help us in the implementation of this project. What are the key achievements? How can we summarize it? Starting from 2015, first of all, СЕТА was adjusted to the Ukrainian context through two randomized controlled trials. Stephanie has mentioned it, but it is one of the few interventions which proved to be effective during the trials, which have very high requirements regarding data quality and reliability, so that we could speak about the effectiveness of the project. Now, speaking about the effectiveness of the program, we know that it reduces PTSD depression system by 50% and improves overall functioning by 25%. Over that time, we introduced certified program, educational program called Transdiagnostic SETA Counseling, and 195 SETA consultants and 235 consultants of SETA psychosociological consultants also went through this program over that time. And I think it is a very important task. We developed a transdiagnostic program and tridiagnostic kit, which is used not only by us, but also by other organizations. We developed the guidelines, which are very practical and which allow for the measuring of the systems which an individual may have. And we can predict the possible outcomes of those systems, assess the effectiveness, and the tools we are using are very effective and they help us in our work. We also developed different effectiveness tools. And as you can see, about 7,000 clients have received services over 10 years. So we managed to help a lot of people. Now I would like to move to SETA project during the full-scale Russian invasion. Since 2022, the project provides free psychological support for Ukrainians who were affected by the war. It is one of the USAID funded initiatives, and these initiatives were also carried out by Chemonics, Pact, Path, IMC, and they also work in partnership with the NGO Words Help. These are the organizations who have been working on in that project within the SETA framework. About key beneficiaries of the program are, first of all, veterans, their families, those who experience psychological distress, families of prisoners of war, and those who are in the conflict zones, people with suicidal thoughts, the risk groups, and victims of domestic violence. So we provide them with aid to overcome crisis situation. So we have about 45% of people who belong to patients who belong to that last group. These are the results of the monitoring and assessment. They show how the symptoms decreased, the level of decrease, and we used our instruments to assess those changes and measure them. This is the level of anxiety, tiredness. So we used a general scale, and we can see that on average in 23-24, more than 2,000 people were assessed. And the level of symptoms decreased by 73%. Typically, it's 9-10 sessions. Some of them get more, some of them get less. And you can see that the decrease, the stress decreased very considerably. And when we finish the treatment process, the patient feels much better. Of course, we have no comparison here. Sometimes, with the time, symptoms decrease by themselves. we received we have also the research figures, and they are a little bit lower, about 50%. But when we are speaking about the introduction of the program in the real world, the figures are much higher, and it improves the life, considerably improves life of our patients. Next slide, please. I would like to say a few words about the role of SETA in mental health support system integration. A previous speaker mentioned it, but I would like to say a few words about the role of this program in the national framework. First of all, the SETA program can be integrated into Ukrainian mental health care system, into a social and medical framework we have in Ukraine. We cooperate with more than 20 partner organizations, and it helps, contributes to effective solution of client. So we know we train people who work in different organizations, so SETA can be integrated into the procedures we are having in Ukraine. Scientific evidence also builds trust, and I think it is very important for Ukraine because the consumers and professional community trust us better. And we should rely on scientific evidence. Another important contribution of this system of work is a decrease in stigmatization of mentally ill people, and ensures the awareness of mental health issues. This program helps us to remove barriers and or to talk to those who are closest to them, whom they communicate with. It's easier for them to ask for help. It increases community awareness about mental health, as I have already mentioned. And we have better opportunities to provide consultations, to express more empathy, and I think it is a very important contribution to mental health system in general. I think the program has sustainable. It is supported by a network of national and international organizations, and they integrated the program into their services. We have trainers, we have experts who went through special training, and they continue working. As I've mentioned, we have a certified program, certified national program, and it allows us to claim that we will continue this program in future. Now we are introducing the services on the national level. Of course, it depends on the external funding. This is what we are working at. We are trying to make SETA services as accessible as possible in order to get more funding. We do not have only, we engage not only USAID, but also other donors. And it helps us also get public funding, seed funding for this program. Economic feasibility, what has been mentioned by Stephanie. I would like to add that this is a non-pharmacological intervention. It helps us to deal with many issues, and it is not an expensive program. On the other hand, it is targeted at the solution of easier programs. When there are more difficult issues, then the efficiency of SETA programs can decrease, and we should refer the patients to specialists. As you know, there are also programs which provide medical treatment, but SETA is non-pharmacological intervention, and SETA foresees supervision and has long-term objectives, and it also foresees additional services or special consulting points which can help with people deal with situations of stress and psychological and emotional tension. It is very important to preserve the resources also of those who work within the SETA project. Here are some other figures. Since 2022, we had 4,749 clients who received individual psychological assistance, and about 55% of them face safety risks. Also, you see that more than 32,000 sessions were conducted by the counselors, and about 4,000 separate safety check services were provided, but they were also very important in the context of war. Now, next slide, please. Criteria for terminating work with a client. As I've mentioned, we have 9-10 sessions, but when we give points to our clients, so when the client gets 12 points out of 63, we believe that a client feels much better, and we can terminate intense work with a client. We also take into consideration our resources, because program possibilities are exhausted when the program has addressed all potential tasks. It particularly applies to clients with psychiatric diagnosis and those clients who require ongoing or long-term therapy, and it's about 2% of clients. There are clients who have to continue treatment under psychiatrist supervision, and it can be a long-term therapy. It exceeds the possibility which we have and which was foreseen by the donors. It is also important that we find also possibilities for the ongoing support. As you know, that long-term therapy possibilities in Ukraine are quite limited. Here are some on the following slide. You see feedback, you see comments from those who received assistance within the framework of the project. I will not read it aloud, but you can see how difficult the conditions we have to address are. And you can also see that SETA is a unique program which can help those who have more complex symptoms. I have recently talked with my colleagues in Sweden. They are introducing this program. and they focus on psychotherapy and something like problem management plus, and they have other programs of this kind. So I would like to emphasize that SETA is a very unique program because it helps how issues can be solved at the level of a community, and also be very efficient for those who have many mental issues and face many mental challenges. Next slide, please. This is the last slide. I would like to thank all our partners from Johns Hopkins University Press, from Kyiv Mohyla Academy, all their ongoing support and the possibility to carry out this program in Ukraine, and the wonderful SETA team. Thank you. Thank you for your support. Are there questions or comments to Serhiy?
Там є питання щодо
конкретизувала, да. Ага.
Yes, in the chat, one of the participants made a comment about the trainings. Are the trainings free of charge? So how do we work? We work with organizations, not with individuals. We organize workshops for the organizations, particularly for veteran organizations, the organizations who have some experience in delivering psychological support to those particular groups. So this can be NGOs, this can be public organizations, social services. We teach the veterans who can work as consultants of NGOs. So different organizations can refer people to us, and then yes, we then take those who were referred to us, and the training is free of charge. But again, we work with organizations, not with people, because it helps us to provide the sustainability of the system. Many veterans work in the organizations, and when they address us and they ask us they ask us to provide some training, they typically have the veterans who work and conduct similar work.
Один із шляхів – це коли є
We
організація,
will be talking about the training. This is one of the steps that the organization is ready to pay for the training of one of their employees in case this organization supports veterans. Okay, briefly, I will also reply to Olena. She has specified the question about triage. The clients were supposed to talk to several providers several times. They didn't feel secure, that they felt that they were pushed around without the result. Another very widespread complaint. Yes, I can wait. If we ask them, can you wait in queue? Then say, yes, I can. So this was misused when the clients would have the stress reaction to one and the same question, so they couldn't get to the professional. So to respond very quickly, so the system of referral, which we have built in the project, of course, it's not ideal, but that's the best what we could have put together. Of course, ideally, it would be if the people would not wait in queue in any case, or talk at least to one person who first tell their story and then continue talking there, to make sure that we would have such one person. This person would be burned out very quickly. That's a huge load to make sure that we can cover the whole process of engaging a client into the program. Correspondingly, if we put ourselves in the place of the client who had to wait for several months, and everybody's asking them how you feel and say normal, and they are sitting and waiting. Of course, they could irritate, but we would try to build up the program that on the one hand could support the clients who are waiting in the queue before they get to a consult. But from the other hand, unfortunately, This must have been not one person, but several. And yes, this could be the impression. And also about the question that was asked, and the clients felt that they are misusing my reply that I'm okay. Unfortunately, not always you can see by the person in which condition they are during this short conversation. Maybe somebody has been at the last point to break down, but when they said, it's okay, I can wait, and the consultant took it, accepted this. Of course, there were some cases similar, and we tried to really take care of it in a very flexible manner. Good, Oksana, I see your raised hand. I would also like to add, it seems to me that it's important to understand that our main objective is definitely was not to miss those people who have some suicidal thoughts and who are directly in crisis because, for instance, something has happened and their condition has deteriorated. It's very clear that a lot of people require assistance, unfortunately many more than we could allow ourselves, take into account what we can allow ourselves and we can afford to provide services in the future, but still our objective is to find and to single out those people who nobody else can give the assistance. That's in the first place, of course, the people referred from Lifeline and some other organizations, because everybody knows really well. We have really nice protocols of security. That was number one. Number two was the people who have gone through traumatic events and who are in the acute stress and who need here and now assistance. Also, definitely, we had some priority categories because, unfortunately, they are also with our donors, and we are forced even to refuse to some people who would not belong to the categories who we could give the assistance. So that's where it's important to understand all the limitations with which the organization is facing us and the consultants, and not only our project runs into these limitations. So it's very difficult to comprehend how all of these limitations look like, which are on the shoulders of everybody who's working. Of course, the clients are not that interested in all of these details. They want just to get the assistance, but we have what we have. And by the way, over the last half a year, in the majority, we have distributed the cases of risks that have become too many. Okay, if you, Oksana, have started to speak, then the next speaker, Oksana Varvarich, will talk about the key differences between SETA approaches and the peculiarities of the training programs, the lengths of courses, the consultants who have gone through certificates. Oksana, the floor is yours. Thank you. Once again, welcome, colleagues. And truly, we can start from the first slide. I'm ready to reply to any questions that will be about the educational process, and much has been said about SETA in general. And most likely, yeah, let's go to the next slide. And something that I wanted to start off, it's about understanding the key differences, because what is SETA, I believe we know more and longer, because SETA has been working in Ukraine since 2016. And Stephanie talked a lot about it, and Sergei has explained about the peculiarities of SETA, and that this is the program of the trans-diagnostics approach aimed at working with the most widespread problems of mental health, such as depression, traumas, psychoactive substance abuse, anxiety and risks, suicidal risks, also violence-related risks, both interpersonal and to the manifestation of violence. So what is CPSS, or SETA psychosocial support? We also call it short interventions from SETA. Truly, we said that these are those services that can be provided at the level of the Hromada for those clients who have moderate or average medium level symptoms of the problems of mental health. But apart from that, when we we with colleagues in 2022, with all colleagues back in 2022, when we worked and we had a lot of people who were in an unstable environment, who recently lived through some traumatic events or continue to go through them. At present, they are in occupation and the like. We couldn't move to full SETA. We couldn't work with traumas because the person, we didn't know whether the person would be able to come to these sessions. And we were missing instruments. We were missing something that what we could do while the person, for instance, is still not sure whether they're moving or not. When the person is in the progress of moving, when they go through symptoms of acute stress. And for this, a lot we were waiting and working with colleagues from the Johns Hopkins University, and we've developed the SETA psychosocial support, which gave us the possibility to have these instruments in which way we can help those people who don't fit so far the criteria for providing SETA assistance. And we can go to the next slide, please. So what are the differences? I don't know that I have such a good slide. So what are the differences between SETA and psychosocial support? To understand what is the difference of training, we have to understand what is happening in SETA and, for instance, what's happening in CPSS. So psychosocial support of SETA, that is aimed for clients who go through acute stress, unstable living conditions, lack of information about future meeting opportunities. Also, this could be some recent traumatic events in their life. And definitely the issues of safety, because safety is a part of any protocols, be it SETA or CPSS, because it's a very important part for us. And when we talk about CPSS, this could be the group or individual format. It could be between 1 and 5 sessions. So this time is enough to stabilize the person who, for instance, is not being stable because of going through acute stress, because we know in order to work with trauma, first of all, from the potential traumatic event, there could be at least 1.5 months. This is truly enough, and during this time, we can already give the person psychosocial support. That's more than PFA, but it's also still not the therapy. Also, over this time, the person can define whether they're changing their living conditions, whether they're staying where they are. Unfortunately, in Ukraine, we have a lot of places where it's not possible to provide to people a therapy because explosions take place every day. Oftentimes, the missiles are arriving, and maybe differently, there could be some time and some support that could be throughout this time in order to help the person to plan the evacuation and to help so they can also go from the place where they don't feel the security in case they really want this. Also, CPSS, we have defined that it's very much useful for the people who, because of various circumstances, don't take medication treatment, including the psychiatric treatment, which is necessary for them. They won't be able to find it. They don't have access to it from various reasons, don't take the medicine that was already prescribed. So thanks to the psychosocial support, we can help such people work with people's thoughts, what could really prevent them from taking this medication, also to help them to direct them, refer them to a psychiatrist to make sure that the person would get all the necessary services which it is possible to provide to them in this area of mental health, taking into account their needs at the moment. The differences of SETA. Okay, full SETA is after trauma, depression, substance abuse, anxiety, safety. It is on average between 8 and 12 sessions. Sometimes it could be less, sometimes slightly more. So the person has to be in a safe environment. The person has to be ready to work with us. And it's very good that when a consultant can work both within psychosocial support and in full SETA. There are also some other options when we have the majority of consultants who are working with the psychosocial support, because it's many more people who require exactly it at the first stages when they refer to the psychological support. And next, among these people who do require a more lengthy therapy, we define such people. We talked about the monitoring form, the other things which we're using during session, and they are already referred to the full SETA, to getting this long-term assistance. In our understanding, long-term, but actually short-term is 8-12 sessions. It's still a short-term therapy, but it's not for the people who require SETA. In terms of the educational process, CPSS, less as a training, it's shorter. This could be from 2 to 5 days to make sure we can learn all the elements which we're using in psychosocial support. It's enough 5 days. And around 5.5 months after this supervision support. So SETA, always, who wants to say how long is SETA? Of course, you all know, colleagues, the majority whose names I see, it's the consultants of SETA who have gone through this way, and they have taken the 10-day trainings. After that, there was some 9 months of the supervision support. Such training lasts for 10 days. In terms of the educational achievements, it's on the next slide. I want to say, when we clarified with colleagues which are our objectives, are we really aiming at providing services as the SETA program, or we still have some other objectives? All of us, 4 of us, Sergei as well, was the number 5. We said no. Also, our objective is training, because it's very important for us to make sure that more people in Ukraine would really learn the evidence-based short-term period, so we would know that our citizens can get high-quality assistance in a short period of time, because we all perfectly understand that the assistance will be necessary for many people. Somebody would have enough for the psychosocial support. Somebody would need the therapy in the form of SETA. And what are our achievements, the ones which you are very much proud of? It's actually since 2022, what had happened before that. Stephanie said a lot, and Sergei too. We heard that we had, until the full-scale invasion, we had more than 200 consultants. Unfortunately, when the full-scale invasion started, many of our consultants started to protect our country. The connection is bad. We have conducted 7 trainings. Oksana has some problem with the connection. I also don't hear Oksana. Oksana warned that she...
Ну, почекаємо, може розв'яжеться.
Okay, let's wait a little bit. Maybe the connection gets better.
Оксано, спробуй зараз нам щось сказати.
Oksana, please, could you try to say something? I apologize. My internet is not as good as I would want it to be. I will try to turn off the camera, maybe it's easier. Now we hear you really well. At which moment did you stop hearing me? You said 7 trainings, conducted 7, somewhere around that. So we have conducted 7 trainings, at which 125 persons were present. Among them, 85 already certified, 36 are still in training. They still need to be certified. For the majority, it will be complete March 2025. That means that only 4 persons at this time have not yet completed their training out of this 125. When it comes to CPSS, over this time, we have made something that we have done for our team, the team that was working with us in this big project where we were giving services. We trained 68 consultants who continued to work with us, so they could work with us both as psychosocial support and within full SETA. Since that time, since 2022, that's even not counting the trainings that we conducted for SETA consultants, we have conducted 14 new trainings. We have trained 190 consultants, 49 of them are already certified, 119 are still completing their training. Somebody is finishing soon, in January, somebody even in December, so very soon this figure will be updated. We are proud with our achievements in terms of training and maybe answering the question which was about the education and training of veterans free of charge or for money. All of these trainings, both for the psychosocial support and within SETA, these were all trainings that in which either organizations were interested in training their professionals or professionals from other organizations. And sometimes big projects when organizations give the possibility to the training for the ones who want to develop their services. This could be professionals from those hromadas where they define that they're missing such services. So a very similar situation with CPSS. All of these 190 persons, these are the people from various organizations for whom somebody was able to pay, the organization where a person was not paying for their training. And we said why this was important for us during all this time, to make sure that the person would have this stable job and would continue to give services in the framework of their job description, to provide more high-quality services, more evidence-based approach compared to services that they used and exercised before. That's all from my side in terms of the educational process. Thank you. And our achievements, colleagues, dear listeners, dear viewers, do you have any questions about the training of SETA? Taking this opportunity, I would like to say that we still have the call for acceptance. Unfortunately, it's not free of charge. It could be by your organization paid or yourself. It will be conducted starting from January 13th. If somebody planned, you can still join in. Okay, let's go further. Many thanks to Oksana. And allow me to pass the floor to our next coach, very well known, Vera Chernobrovkina. And the topic of her presentation, it's the peculiarities of working with traumas of the war. Everything that is connected to a lot of cases. There were about working with traumas related to war, physical, sexual violence, childhood traumas, and situations of undetermined loss will be discussed. So, Ms. Vera, the floor is yours. Thank you, Pablo. So please, let's go to the next slide. Basically, that's the name of my presentation, and you can switch the next slide, please. So this is like some generalized idea that pertains to the fact that the trauma cases, that's truly the most significant and most substantial part for the work of SETA consultants during the war, especially. And truly, SETA was created, was designed as the short-term evidence-based intervention, or the group of interventions for people who have gone through some very difficult experience, especially of the traumatic character. And let's see at our experience in the framework of the work during the war. The next slide, please. So we have generalized some data, which is not coming from the research, it's coming from the monitored. Thank you, Alona, for provisioning of this data. And basically, in order to present this part of our work, we have taken the data from our system, which is the basis of our data, and it was implemented in August 23. This is the dynamics. And over this period, starting from 23 and 24, we have completed 562 cases of full SETA, in which there was the therapy of traumas. So altogether, the cases of full SETA were 1,138, and this 562 of complete SETA, they are actually constitute 41% of the cases of full SETA. If we take all cases that were completed within this period, we actually had 3,175, because it also includes some cases CVSS, and also cases with trauma represent 27% of the total number of clients.
Це суттєва частина, тобто з повної сета 41% кейсів, це кейси.
So the overall duration of trauma cases during the war has increased. Next, it's very important to look at the lengths, at the duration of trauma cases during the war. We can see the tendency to increase. The average duration is 14 sessions, but we do know that in the pre-war period, I mean, before the full-scale invasion, until this phase of the war, we very seldom got out of 12 sections. This was some extra cases, and possibly we were like for 1, 2, 3 sessions outside of these 12 sessions. And now we can see that the most lengthy case that we have in our experience is actually 33 sessions. But also there are some short cases working with traumas. There's this minimum number of sessions is actually six sessions, but the average length duration is 14. So it's quite exemplary. And in general, we say that we are really seeing this tendency when very often the work is not complete into these 12 sessions. So we are seeing cases which we are resolving, and we decide to continue working with them. So in case we talk about the traumas, about the nature of these traumatic events that is going on during the war, then definitely we have an increase in cases involving loss of dear ones, close family members, comrades, friends. We can see this tendency when we are even sorting cases. We can see requests. We just simply see that there are waves when there is the increase of the number of requests from people women and men who say in their requests that they have lost somebody very close to them. And also there's been an increase of cases involving recent traumas, and that, of course, brings these cases automatically to acute stress, to CPSS, and also there's been more referrals with some recent traumas caused by recent events that can already be maybe not the acute stress, but early phase of formation of symptoms of PTSD. Next slide, please. It is interesting to see how successfully completed cases break down to age groups. We can see that if there's been also a small group of adolescents before 18 with whom we worked on the trauma. We worked with adolescents until December. With some we continued in December and January 24. But in this project, which we had this year, we already didn't work with adolescents, exclusively with the adults. But in this number of cases, 462, we had adolescents, you can see 4%. And in general, a very interesting distribution into age groups. And also this histogram looks almost like a normal curve when the average medium age 34 to 44, that give us the most significant groups of clients with whom we worked on these traumas. So you see, we have even 1% of people who are older than 65. We can go to the next slide. That's where we can see the distribution of trauma cases between various categories of people. When the clients turn to us and they fill in the form of requests, they choose the category that they belong to. This is not full, I will read it out. First category, it's IDPs. They constitute the 1/4 of all trauma cases successfully completed, namely 24%. Then the dwellers of the occupied, then the persons with disability, gone back from captivity, people who have lost their dear ones, 8%, veterans 5%, and the persons who suffered from various types of traumas connected with the war. Also from the traumas of violence or tortures, it's 3% among this group. 2%, it's the persons who have received the traumas with limited movement, and another category is different. We also have the members of the family of the active military men who are at the front, also the citizens of the territories which don't have the military activities, that don't belong to IDPs category, and the people who are in crisis and who ask for help. And looking at this distribution, looking at these figures, I thought that in the future it's important for us, the categories of the members of the family, the military that are at the service, we have to separate them into a separate category, and we will be able to allocate these persons more.
As we can see, we are most effective in IDM group and their traumas with veterans and those who lost their dear ones. Next slide, please. I have interesting data. Thank you for Alona. And Maybe here the figures are not very precise, but we can see the overall picture, and we see that 88% were only the traumas. 88% are only those who had one kind of trauma. 10% of cases were traumas where we also had a depression and had to work with depression symptoms and had to work with the depression. We know that sometimes working with trauma sometimes reduces depression symptoms, but it doesn't always happen. So we have to add some other kinds of therapy and recovery therapy. Sometimes trauma was supplemented with drug addiction, and very often after trauma, we used the exposition as the basic element. This is how the figures and the monitoring looks. There is also additional information which we may find useful. It concerns the peculiarities of working with trauma. I conducted several interviews with the supervisors. I'm very grateful to all those whom I worked with. I asked to identify those clinical features which are observable and which trainers and clinicists see most often. And the most important peculiarity is connected with taking clinical decisions. We often have to make decisions understanding that there are no really safe places in Ukraine, and there are regions which are safer. There are less safer regions, but there are no safe places in Ukraine, and it's always a very difficult decision to decide how to deal with trauma in that situation. When at the beginning of working with trauma, we thought that those who live in Kharkiv and in Zaporizhia are not those clients who should be treated for trauma, but practice corrected our approach. We started client situation. We interviewed the client. We talked patients. We asked the patient how the patient feels during the shelling, during the alarm. Although we know that these are dangerous places, and we know that the place is close to the front line, but the client says that she feels rather safe, and then we decide that we can work with trauma in those cases, and we work with the trauma in those who live in Zaporizhia, in Sumy, and in the areas which are very close to the to front line. Of course, it is a risk because we never know whether the client will be in a safe place, and we are plunging into his or her trauma. There are cases because there are also some peculiarities during that often happens during the war. There are different medical medical events, there are losses. Something may happen like next door to the client, and it often affects our possibilities, our when we follow the sets, but we cannot work with the trauma because a person is undergoing some traumatic events. We terminate working with trauma, and we introduced elements of psychological support, and then go back to trauma when the person, for example, buries a dear one who died, a close person who died, and undergoes and finishes the process of mourning, and then we continue working with trauma. Or if a new trauma is more powerful, then we work with a new trauma. But each case is unique, and we make a decision based on the clinical, specific clinical picture. Another peculiarity is that very often when a client is undergoing therapy for war trauma, when we build timeline and when we select an event to work on, other traumatic events and symptoms emerge, and these are the symptoms or events which took place much earlier. And very often we work not with traumas, with war traumas, but with traumas from of the pre-war past, sexual violence traumas, domestic violence, incest traumas, death, children's death, parents' death, or even traumas from the childhood. So this is a very interesting peculiarity. I think it's something that clinicians know and psychologists know much about, but still I think we are having a unique experience in Ukraine working with trauma, and in war context. All the results of all previous research become reviewed, and we view at trauma differently. It is a unique experience worth researching, discussing, and being written about. Also, another peculiarity is that a number of sessions with trauma, with working with trauma, increased. So standard is 3 sessions. It's a standard approach, but we often say that we might need more sessions, and in wartime we can see that 3 sessions is not enough. That's what we know from our experience. Also, the clients more often come to speak more often about their limited resources, and they often say that I should not plunge into my traumatic memories because it might be too difficult for me to deal with those memories. It is natural for working with trauma in general, but in wartime, such thoughts become more acute. And it's very difficult for clients to do their home assignments. It was also mentioned during the interviews. Also, clients often come to us with new trauma, and it's a natural practice during wartime, because they can be traumatized again and again. Also, we encounter the cases when psychologists and other assistant workers come to us. They work with people in those places which were shelled. We work with witness traumas. We call it secondary trauma. And it is a situation when a psychologist, an expert, was not a participant, but he observed something, or observed the consequences of trauma, or heard about it, or learned about it, and hearing the stories of what happened. Those who work with psychological support are also affected by those memories and those events, and they can also lead to trauma. And the last slide I would like to focus on. Can I see the last slide? These are the thoughts, unproductive thoughts related to trauma, and which are connected with cognitive restructuring of the experience, because we know that clients should be exposed to traumatic memories. This is one thing, and another thing is working with traumatic thoughts, which are connected with how a person interprets a traumatic event. Well, Pavlo will speak about it in more detail. He will speak about the veterans and their families. I will speak in more general terms. What are these thoughts? Thoughts of personal guilt. These thoughts are very traditional for working for trauma in general. Thoughts of not saving the loved one during shelling or occupation, for not leaving on time at the start of the conflict, for not stopping loved ones who went to the front and perished there. So here, the sense of feeling of guilt can be very, very deep. Thoughts of blaming others, other people, authorities, relatives, and so on. Also about those who can be blamed for thoughts of those who can be blamed for the current situation. Also, something I heard during the interview, it was repeated many times by many interviewees, thoughts about the uncertainty of the future. We think that these are depression-related thoughts, but they often emerge after working with trauma of loss, or traumas experienced by those who left the occupied territories. How do we live? What will happen next? I can't see my future. Life will never be the same again. I'll never be happy. So these thoughts contribute to the creation of a depressive context of perceiving life and the world in general. But these thoughts emerge after trauma, and of course, thoughts about the fear of similar events recurring in the future, the fear of new occupation, the front line approaching, the fear of relaxing and missing the right moments. That is what I want to say about clinical peculiarities. I haven't included it into the presentation. We don't have a slide for it. We tried a new setting in our work with trauma cases. There are two interesting examples when in the military hospital, when we have military injured military, we had 7, 8 trauma sessions, and they were quite successful. And this is a setting where we could have 3, 4 sessions during 1 week. So we managed to carry out those therapies over a very short time. And the second example, it was in days back to 2022. The psychologists working within the framework of USAID-funded program, they worked with trauma with women who needed a recovery after what they experienced, and we tried to build the setting in a way to finish work with active work with trauma in 3, 4 sessions, and then we had extra time to continue working and enhancing the results. So we sometimes accelerate our work, and it is a justified approach. That's all for me. Thank you, Vira.
Дякую. Я бачу, що ми тут по таймінгу трошки виходимо за його рамки, тому якщо є питання,
Okay, we do not have time for questions because we have 2 presentations and we have very little time left. Nina also has an interesting material about security. I'm Pavlo Horpenko. I'm the next speaker, and my presentation is connected with veterans and with their families. If you have questions, could you please write them in the chat? I would like to begin with maybe the next slide, please. Next slide, please. Yes, there is a question whether can get the slides of the previous report. I suspect yes. We will tell you at the end how to do it. As regarding cases which are connected with veterans and their families, first of all, the data which you see here is not very realistic because it's only 23, 24, and the number of veterans and those who turned to the program, well, they are not, these figures are not very accurate. So these figures, I guess, are much higher as regards the tendencies which we can observe. So the number of the military who come to use SETA program is increasing because they are either injured or demobilized, and we can assume that the number of such clients will increase. We are consultants who specialize in working with veterans. They understand the military, or, for example, they work with veterans beyond the framework of SETA program. We have those who can work with the veterans, is willing to work with the veterans. Later, in SETA, we work individually, but at the end, I will also say something about working with groups. As for the groups, we work with women, groups of women whose husbands were either prisoners of war. We conducted CBSS groups, and then if the participants wanted, or if there were many symptoms, we referred those women for individual work. And another example is that at the beginning we had requests from military units who wanted to ask with the soldiers who were to be rotated. It was something between decompression and work with war-related stress. Now we have more psychologists in the army, but at the beginning of the war, it was quite a problem, and I would say that it was a very positive experience, because SETA is an excellent tool, an excellent project to be used, and there is a demand for this kind of work, and we can assume that the demand will still be high. Additionally, we work with veterans and with their families, and so one of the consultants may work with a veteran, and another consultant work with a wife or other members, but typically it's with wives. So we have a lot of experience. Next slide, please. As regards the therapeutic plans which are used with the veterans and for the veterans, most widely used therapy is trauma therapy and combination of trauma and substance use. Well, of course, there are exceptions, but that is what we see, what statistics show us. We should also understand that we cannot work with the acting military. We work only with the veterans. But the consultants I mentioned, those who work with the veterans in other projects, they often work as volunteers, and they use SETA possibilities to support the military and the veterans. And also, previous speaker mentioned that they work also in hospitals, in military hospitals, and the challenge is to go through the whole SETA protocol in an accelerated way, and to have more, it means to have 2 or 3 meetings, and I think we have cases like that, and I think it's a very good achievement. It's not always possible because the general health condition of the military do not often allow for it. CPSS 16% received, 16% of the veterans received it. The veterans undergo therapy, and sometimes when they have to go back to return to their military unit, we cannot work with trauma. We just want to stabilize their condition, to balance their condition, and to recover psychologically. As regards family members, work with family members, the most popular SETA element is the recovery of activeness. It is one of the most widely spread, and Alexander Aliyev, one of our members, he was a former member of territorial defense unity. He worked there as a psychologist. He worked both with groups and with individuals. He used triangles. So, and he said that it was very well received, and the point was only to find the experience which will be most suitable. Next slide, please. As regard work with trauma, Vera told you a lot about it. I will be very brief. For veterans, firstly, for the veterans, the stories which they used for work with trauma were connected with traumatic events, losing their comrades, injuries, and traumatic history was often the history of loss, and there was a sense of guilt. They are very frequent, and we encounter them more frequently than the situations connected with self-injury. So trauma which soldier suffers because his comrade perished is much deeper than the trauma because of self-injury. As for family members, traumatic experience of family is often connected with a pre-war experience, with domestic violence, with childhood traumas. And those traumas were more numerous because yes, of course, there were also war traumas, losses of the loved ones, uncertainty. These traumas were also quite widely spread. As for working with thoughts, the thoughts are the situations of loss and thoughts about this, blame thoughts. I didn't do something and my comrade died. As for family members, the most widely spread thoughts is I'm bad. It's a wife often thinks about it. I'm not what I should be. I don't know how to live future. Surprisingly, there were many situations connected with the relations when the husband is in the front line and the wife is in the safe place. There were often divorce cases because the wife might have met someone, or the husband could have found a new woman he wants to be with, and such situations happened very often. Another situation is connected with motivation. Why do soldiers go to ask the psychologist? Because my wife told me that she will divorce me if I do not consult the psychologist, and this is the element which is very important, the inclusion to therapy because of such comments. It is important for the military to believe that therapy can be successful. The military said that it is very important to give you a chance, but they often say, I don't believe in therapy. You can share some experience with me, but I don't believe it will help. That those only when soldiers see that when they see that the therapy works, those methods work, then there is chance that the therapy will be completed, because when therapy is abandoned, it usually happens during the first or second session. Another particular feature is that the military try to avoid working with trauma, and very often we have to remind the military that working with trauma means is helpful, can help, and that many those who did it managed to overcome trauma and traumatic thoughts. And when they very often when the military went through trauma therapy, they admitted they didn't believe that this therapy will help. You can see the statistics data.
21 зустріч, тобто, що в середньому все-таки...
So maximum is 21 meetings. So we have the standard of 7-8 sessions, but actually there was some longer cases And the last, as far as I remember, the last slide, it is connected with the...
Про це я вже трошки сказав, можна наступний тоді поки що перелиснуть.
Yeah, we can go to the next slide about the comorbid disorders for the veterans, for the military. Most often with the trauma, we have the abuse of alcohol very often, as well as using of other substances, also the game dependency. And once again, the achievement of SETA was working of a lot of cases when in parallel the consultant was working with the element of decreasing the usage of alcohol and also game addiction. And we have quite a lot of positive results where we were able to either stop or decrease the usage of alcohol and stop this gaming dependencies to make this process controlled. The cases related to safety, maybe they were not as much. I mean, 1/3, of course, is not that small, but nevertheless, this is not like too much. Maybe Nina will talk in more detail about this. And so one other challenge, which we still quite characteristic, we don't have these cases, it was homicide. It's when the military have the intention to do harm against somebody in case they have access to weapons, and the military do have access to weapons. So the consultant has to treat such cases very seriously. And there were cases when there were no suicidal thoughts, but there were also homicidal thoughts. So we also used some measures of safety. You understand, unfortunately, that is happening quite often with veterans. So thanks for your attention. Thank you, Paulo. And thank you for your performance. And in case there are any questions, you can also write into chat. I will pass the floor to Nina Kokoeva. The topic of Nina is working with the cases of safety. I know that we are above time, so I will try to super quickly bring you to your knowledge most important information. Vera said a lot about working with traumas. This is one of the most important elements, and it's not that we are like competing here, but as Stephanie said, it's difficult to see which element is actually priority because all elements of the work are important, and it was actually about the security. It's quite emotionally difficult for our consultants, but it's also very important in the context of working in Ukraine, because definitely we can talk that we have the unique protocol of working with the safety, and we know this from colleagues from other organizations and also from our partners, from the Lifeline, which are guiding clients to us, that this volume of works with security that is done in SETA is not done in any other program of Ukraine. We can go to the next slide. If we talk about the system of referrals and we say in which way the work is done with cases of security, we have created the team and the system of response to make sure we can disclose clients with the safety concerns as soon as possible. We have several operators as well as the team that would be responsible for conducting the calls and introduction of primary protocols of safety. That's the operator for consultants and 2 supervisors of the security supervisors, safety supervisors. All the team is trained with safety risk assessment protocols. You know this. It's the suicidal thoughts and intent to harm others, and it's risks of interpersonal violence. If we talk about the system of operation, you heard numerously from trainers, and during this training, that security is our priority, and it's really so. the safety of all clients of SETA has the priority, so we have created this system of super quick response to these events when the clients, when they have one of the risks of security. So we have some additional call throughout 4 hours who is responsible for the security, and during 48 hours we appoint to such a client their permanent consultant. So this type of work allowed to, as quickly as possible, respond to such requests and not to keep our clients alone. You have read the responses from the previous presentation that were from clients. That was appreciated, that we can quote one of the responses of the client, that he was asked whether there is this safety plan is there and it's vital. Let's come to the statistics. If we talk about the general number of requests with the safety, yeah, we can go to the next slide, please. So we have found out throughout 23-24, 1,017 events from security. We can say that every fourth and even more of the clients with whom we have worked had these risks of security. We can say that and 770 people. I will stop for a second. I want to make sure that everybody we have some problem with moving slides.
Тепер табличка є.
Супер, є. Так. Це те, що я зазначила.
Also, that's what I have mentioned. That in general, using the categories, we will say that we have more clients who have turned to us. They were women. It's this proportionate distribution. If we talk about the age group, we can go to the next slide. We met with the security also with clients who have the age below 18. This is not our target group, but take into account that we were not able to leave the clients with risks without attention, take into account the limited services in Ukraine. In any case, for working with children, we have foreseen the primary safety plan and referral to the next services. And if we talk about the distribution of risks of safety, of course, consultants know it 100% from their experience. Very often we see the risks when there are suicidal thoughts, and the risks of security is variated from low to high, because it's also foreseen in our program. But we always take into account the peculiarities of clients, the peculiarities of their answers to questions, to make sure we can define the most effective response plan. If we talk separately about the categories of 18-24, that's the category we have set this risk of security. It's what we call the self-harm as one of the risks of committing harm. In order to safeguard these clients that we have already seen. We can also switch the slide. And once again, if we talk about the sessions that was the components of safety, that was 10% of all sessions, and separately we didn't count any additional sessions that include the safety checks. We call it check-in safety. It's not always the full-scale session.
Лише в 24-му році у нас було здійснено 1590 чекінів безпеки. Тобто
1,376 calls where the clients would require more support, more often than traditional sessions once a week. Altogether, if we talk about the number of clients with security risks who were receiving SETA sessions, it was 495, and the clients with security risks receiving exclusively CPSS sessions, it was 623. And if we explain the difference in these figures, this was talked about by my colleagues, that it is by the conditions of stay of our clients. It's also about the availability of certain disorders which don't allow us to move in the full therapy with clients, but that level of assistance that we received as part of the psychosocial services, it said that the person could keep themselves in safety. We talked about other specialized services. We have such interesting figures. It's was 11 sessions on average. But once again, if we look at the minimum and maximum number of sessions, we can see already 33. That's mostly the exception, but it's important also to say that very often the clients with security, with safety, require a more lengthy therapy, more work, and we're talking that the consultants are spending more time to give the necessary support to such clients. And very often the therapy unites in the first place the long-term work in SETA, psychosocial support, and after that, after stabilization of the safety issue, we can go, whenever this is possible, to the full therapy with the client. We can go to the next slide. And if we talk about the main peculiarities of the client, it's the clients who would have the morbid disorders. This was like combined plans. This was depression and therapy. It's working with the case of security and also with guiding to the psychiatrists. That's a separate block of our work on which we are actively working this year. And I can say that a lot of our consultants faced objective difficulties that they had in the context of referrals. So altogether, if we talk about the statistics, once again, the number of clients with security that were referred to the psychiatrist was 15% from the whole case of cases with safety. And the referrals were at different stages. Not always we were able to see this at the first sessions. And very often the clients could see about the availability of certain diagnoses, or the consultant could see the necessary services throughout the first and the second session. And the reasons why the client can turn to the psychiatrist. Also, we were turning by the clients who were at the treatment, and they were also referred to SETA. And in case we talk about the main difficulties that existed in the work of the psychotic cases, we of course should mention stigmatization, that there is this stigmatization of psychiatric assistance as well as stigmatization of safety problems, and this is connected with the fact that not always the clients would have the access and not always would have the readiness to turn for psychiatric assistance, even though it was objectively necessary or their current condition. And maybe the next slide. And if we talk, I have collected information from my consultants. I know from the experience of my consultants, I've asked the colleagues, so we have formed a pool of this main diagnosis, which we have met during the therapy, and those of our consultants, the ones who are present, colleagues, you know that for every diagnosis, we have a certain peculiarity of work. Not with all the diagnoses we can work, not with all the diagnoses we can make the therapy. So we have defined this together with supervisors and with the coaches, the level of intervention. This could be the SETA therapy of the symptoms mentioned by the clients in parallel when the client has also psychotic disorders. Very often we would find the following parameters as generalized anxiety disorder. It's also the clients with anxiety depressive disorder, bipolar affective disorder, with obsessive compulsive disorder, with borderline personality disorders, which were also ADHD and eating disorders as well. Altogether, if we're talking about the statistics, the ones who were referred to the psychiatrists in 2023-2024, we had 320 cases, that's 10% of the total number of clients. Also, in the same way, it's the first referral that was in the process of work of SETA consultants. We had clients who have worked with the psychiatrists but requested psychological assistance to our program, and we had 400 psychiatric care, and this was 475 clients. The next slide, please. Among these peculiarities of work with psychiatric cases, we said that the SETA consultants was important to get the confirmed diagnosis of clients. We often saw that when we have the request from the clients would name the diagnosis that they would had previously set up, some maybe 10, 20 years ago, that could be no longer actual, and some clients could call their diagnosis from words. We were not sure whether it was properly diagnosed. So one of the reasons of this referral to the psychiatrist is to get the actual diagnosis. It's important that the clients would have the stable contact with the psychiatrist to get the on-time medication treatment. We talked a lot with the clients about the importance of awareness of the risks of safety that the client has, and I know a lot of consultants even wrote the plan in which way the client can inform the psychiatrist about the available risks. And the best option was when the consultant of SETA had the possibility to contact the psychiatrist in order to approve the therapy plans, and I can tell you that this would be the ideal option. Not always we would set up this option, and this was connected both with the peculiarities of, let's put it this way, the confidentiality that was perceived by the client, with the openness of some psychiatrists to the contact with SETA consultant. So what we did additionally among these opportunities, it's also about the clients who had their psychotic disorders. We did the support of resistance and stigma regarding psychiatric visits. We worked a lot. We used the elements of the timely decisions when the clients would have the deficit of information on when they didn't know what could be the resources in terms of referrals to psychiatrists. We worked on some warm contacts with some psychiatrists in Ukraine. It was very helpful for us, this Lugansk Center of Mental Health. And once again, it's important to have this interaction because we know that the free of charge psychiatric care is also, in case we talk about the safety cases and the cases with psychotic, and that's all. I tried to be fitting into this limit time-wise. In case you have questions, I would be ready to answer. Yes, there are questions. The number of referrals, Anastasia writes, it's how many clients were guided and how many clients got the services. It's how many, or both, guided, yeah. It's how many clients were received and got the service of the psychiatrist. So we're talking about the stable work of the client. This was one of the conditions, and the consultant, the client worked differently. that this high-quality assistance was a condition of getting psychological support in SETA to make sure that the process of therapy would be successful for the client. I can support that that always worked, very often worked. Thank you. It's interesting for me, some statistics in case, what is the number of psychiatrists came to see the consultants of SETA. Unfortunately, we don't have this figure. And we said with Alona that it's difficult to count, and our specialists from monitoring did a huge work. Also, the colleagues objectively know about it from the recommendations, who are the colleagues of the psychiatrists talk to our clients, and to the context of clients. It's a subjective information that we definitely somewhere is available. From my side, I want to say in the end of this speech of Nina that these cases with psychiatric diagnosis, it's exactly that part of the work of consultants that actually had the biggest difficulty among consultants. When we first saw the massive referral of SETA clients, we as consultants, nobody ready, and it was all in process. And SETA Global was joining with, let's call it protocols or some recommendations how to work with such cases. Then it was easier. But basically, we need to give credit to your resistance, to your heroism. Yeah, we have also a question of Oksana, how to engage a project and to work. Well, I don't know. Are you already a consultant of SETA? That's a question. Are you how to become a consultant or how to join a project? We can contact you separately. We are now finishing the project 1. It is almost over. And
які вимоги до кандидатів у консультанти? Ну, якось важко мені на це питання коротко, так, щоб не затримувати. Я пропоную
тоді... I don't know how to quickly answer it. I suggest that you talk to us, and maybe we can talk individually about that. Miss Olesa, and in the first place, in case you're talking about training, the requirements, it's most important to have the specialist education, but it's not, it can be discussed in any individual case, but it's most importantly the access to the clients with whom SETA can be used. So it will be more important over here. I just wanted to say that now what we have is the selection of a new group and the requirements to candidates. We are going over them when we are making these interviews or interviews with each candidate. So the requirements to consultants, it's requirements to consultant for training. So we are going over these requirements exactly during these interviews. That's access to working with clients, availability of job experience, that you're working in organization and you have the possibility in the nearest year to have access to clients to whom SETA can help, and that you're working with clients and that you're seeing problems when the instruments that you know are not enough, that you would be helping effectively to them. Apart from that, there is a number of some very specialized requirements connected with your emotional resistance, if you're ready to stand the experience working with difficult clients. On Oksana asking a question, then I suggest to talk to us, contact us, and we can talk individually about that. Actually, I wanted to add, okay, you don't see me, but I'm here for my internet, that's critical. So I wanted to add, because I personally received a question from the consultant, how to become a member of the team and how to work with us. And unfortunately, nowadays, we are not adding people because of the shortening of projects. We said that we have big queues, and the big queues are, since we don't have enough financing to make sure we could cover the needs which is there. So we have a lot more people talking to us compared to what financing we have for the provision of services. And it was necessary to shorten the team. We don't know what will be the next one. This is connected with, actually it depends on our donors, because we understand that the biggest donors, it's the United States, and we all understand that there are possible changes in the politics, including in the grants that will be in the future. So nowadays, we are not expanding the number of consultants who we have, but also we are decreasing them. But we believe that nothing will go away and there will be other projects. We are always searching for the possibilities. Alexander, who was preparing this conference, she also has been working a lot on this. Sergei Bogdanov is working a lot on that to have the possibility to search for the sustainability of SETA, because these services are necessary. We can see this because of the number of requests that we're getting, that we are able to close the forum. We don't have the possibility to give services to everybody who needs it. So we'll keep you informed in case we have some new possibilities. I see that Oksana Gerasimenko is Oksana Kitsa. It's our consultant. I understand who you're talking. I didn't know that you are Gerasimenko. So you already have the consultant education. And in the light of what was said by Oksana,
це ви не сертифікувалися.
You're not certified. Okay, great. Okay, it will be more easy for you to do this. You have started this way, but this has to be solved individually, and we will have more consultants. Good. Many thanks, colleagues. It looks like we have finished our conversations and our reports. Many thanks for being with us half an hour later. So once again, are there any questions that require some answers? Thank you. So we thank you. We would like to thank everybody who has joined the conference. Many thanks who have not joined but joined SETA. Many thanks for all your effort, organizational, educational, and the rest. I think we're making an important course, and may God bring that our effort don't go away, and we should continue this doing, because there is a big request to this. That's all for today. Hugs to everybody. Stay safe.